All right, well, good morning. Still, good morning, right? Yeah, for another hour and a half or so. Now the paparazzi has done their job and we can get started. I want to start by just reminding everyone that this session is for ACHE credit, but you need to sign in for that, and I think that's over here somewhere that they can help you do that. Thank you for attending this session. This is the all-star panel. This will absolutely, without doubt, be the best session of the day. So you made a wise choice by being here. Congratulations to you on that. So I want to start with some good news. So in July, the July labor numbers just came out. In July, total employment in the healthcare industry finally reached the level that it was in March of 2020. So there are now as many people working in healthcare as there were in 2020. That's the good news. The bad news is that the demand and need for healthcare workers is substantially more than it was during that time. So even though we're back to the number of workers, where people are working has actually been has changed quite a bit, and there's been a real redistribution of the workforce. So employment is up in physician offices, in outpatient facilities. It's actually up a little bit in home health. Employment in hospitals is still a little bit down compared to where it was 2.5 years ago. And most frighteningly, employment in nursing homes is down by 15%. 235,000 fewer people work in nursing homes than they did just 2 years ago. In case you have been living under a rock or in a cave, there are challenges with nurse labor, nurse staffing. There are roughly 200,000 nurses who left the profession in 2021. And actually, let me say that more accurately. There are 200,000 fewer nurses working at the end of 2021 than there were at the end of 2020. Something you don't hear as much about in the media compared to nurses, but it is actually perhaps a bigger challenge, is in with some of the other nurse-related professions. Nurse assistants, there in 2021, total employment went down by 10%. Vocational nurses in 2021 went down by 20%. 20% fewer vocational nurses working than there were a year and a half ago. Really interesting McKinsey study that came out this summer of nurses, kind of an attitudinal survey. According to McKinsey, this summer, 65% of nurses say that they will likely leave the profession. 2/3. 34%, just over a third, 34% of nurses say they will likely leave their job this year. Now that's not necessarily saying they're going to leave the profession, but will likely leave their job this year. 1 in 3 nurses saying that that's likely. Obviously, a lot of that has to do with pay. And again, nothing new here, but over the last 2 years, pay across all healthcare professions, so this is just a large number, macro number that looks at the entire industry, but over 2 years, pay in healthcare is up by just over 15%. That's compared to about 12 or 13% in the economy overall. But if you ask nurses now, and this has changed really over the last 6 months, those nurses who are saying that they're likely to leave their job, pay is no longer the number one issue. It's actually fallen down to somewhere around 5th. The number one issue, 44% of nurses saying the reason they're likely to leave their job is because of burnout. Speaking of burnout continues to be a big topic among physicians. 4 years from now, 21% of physicians will be retirement eligible, meaning 1 in 5 doctors 4 years from now will be 65 years or older, and the American Academy of Medical Colleges is forecasting by that year that there will be a physician shortage of up to 100,000 physicians. And that's just kind of at the macro level. If you start kind of digging down into different segments of our industry, you start uncovering more challenges. Behavioral health is a particular concern, and I would argue coming up on emergency status. There's a forecast that by 2026, in 4 years, there'll be more than 500,000 shortage of behavioral health workers. Now, not surprisingly, all of this is really taking a toll on leadership in healthcare. And I don't actually have any hard data to share with you on this, but I can tell you we do a lot in this space. And we are seeing levels of turnover among healthcare leadership, hospital administrators in particular, unlike anything that we've ever seen. So, other than that, everything's pretty good. No real problems here to deal with. The good news is that, as I said, you have an all-star panel that is going to explain all of this and how we're going to fix it and deal with it. And so you get to hear that from them. So I do want to just very briefly introduce our panel, and then we will jump right into it. I will start, actually I'll just go down the line here. Dr. Monica Swan is a psychiatric epidemiologist who serves as Dean of the Wellstar College of Health and Human Services at Kennesaw State University, as well as a professor in KSU's Department of Health Promotion and Physical Education. She also has the best accent on the panel, so you'll want to hear her speak as much as you can. Next is Dr. Deep Shaw. Dr. Shaw is an owner-operator of Gwinnett Clinic, a multi-specialty independent practice with 18 locations across Northeast Atlanta. He is a native Georgian, also a fellow GAC Spartan, so go Spartans, we got another one out there. And he practices full-time primary care and holds multiple leadership positions in the healthcare community. Next is Dr. Miller Goldsmith. Dr. Goldsmith is a board-certified emergency medicine physician and owner of Goldsmith Medical Services. She practices as a locum tenens physician and is the incoming chair of the locum tenens section of the American College of Emergency Physicians. And last but certainly not least, Dr. Laura Daniels serves as Chief Talent Officer at Wellstar Health System. She is also an adjunct professor in Human Capital Management at Columbia University. So please help me welcome our distinguished panel. Dr. Goldsmith, I want to start with you. And you know, we talk about all of these numbers of people leaving clinical care especially, and one of the words we hear a lot is burnout. And so just to kind of set the stage of where we are, I'd really like to ask you from a physician's perspective, talk about burnout. What's happening, what has happened, how is this impacting the profession?
Sure. So yes, I'm a practicing emergency medicine physician, and I think the sentiment across medicine in general and across many of the other specialties is that the past 2 years has placed us in a position where we're reconsidering or just rethinking our approach to medicine. Emergency medicine has always been one of the professions where there's a chance of having high burnout, but I think definitely going through the COVID pandemic, it definitely shed more light on that. In terms of what I see in the emergency department, and I'm sure other people can share this experience, is that the decrease in resources and lack of resources has also put a strain on us in how we deliver care. I know we'll talk about this further. Decreases in nurses, as you mentioned. It affects our ability to fully staff the hospital, and so we end up with fewer beds in the emergency department to take care of some of the sicker patients that are walking through the door. So as you can imagine, that puts a lot of stress on a physician who still is expected to actually take care of these patients regardless of what resources we have. And so that's something that we face, and as a locums physician, that is one of the ways that I have protected myself and my mental health from burnout. And I know that across other specialties, there are other people who have come up with some creative ways to try to protect themselves as we're, approaching medicine in different ways.
Yeah, thank you. You bring up something that we hear a lot, which is a lot of the burnout is caused by having too many patients to take care of. We hear this from physicians. We certainly hear it from nurses. And it causes them to leave, which causes the staff that is behind to have even more patients, right? And it's kind of this cycle. Dr. Shaw, I'd like to turn to you on this, because you can talk to this from two different perspectives, right? As a practicing physician, but also as an employer. And so just kind of talk about this issue and kind of the state that you see clinicians especially today.
Well, we're in a unique place in healthcare, and Shane sort of jokingly said, this is the most important panel of the day, but it is, because all the work that everyone in the room does is ultimately dependent on the delivery of care service at the bedside. So without clinical staff to do that, or administrative staff to help us take care of patients, what ends up happening is the amount of care being delivered has to shrink, to Dr. Goldsmith's point. So I run, along with my family, my parents started this group in the early 1980s, what I believe is the largest independent medical group in the metro Atlanta area. 2-3 years ago, when we started taking care of COVID patients and COVID testing, is when I think all the underlying staffing issues were exposed. And we started experiencing overnight mass resignations, people having to stay home with their children, and you saw all levels of leadership starting to get involved with hiring and staffing. And that is still the case today. And just to put it in context, it's interesting to be at a healthcare conference based in the South, but now we have so many national and even international companies here. I see groups from Novartis, Amazon, at the same table with me, a local business owner. So what's happened is a small practice in any part of this state is now competing with national and international players for the same talent, which is obviously an uneven playing field. But the question I'd put back to all of you, our colleagues in the sector, is when you're sick and you see the doctor, you want the best possible staff there. So when we think about collaboration, the question that we have to ask is, how can all of us work together to improve the bedside staffing? I'll just make one more point about this. Many of you in the room are principals or leaders wherever you work. And you probably know somebody at the local doctor's office or the local hospital. So when you call, something gets done for your loved one. What we all want is a system where you don't have to make that call, and everybody's treated like a VIP when they walk in the door. And that's all about staffing and humans. So I swabbed myself with the help of core consultants who got us up and running over 1,000 patients the first month of the pandemic. And yes, I'm proud of that, and I'm sure Dr. Goldsmith did the same, but it's not a great use of physician time. So we have to really start from the foundation, which is primary care, and try to build that infrastructure.
Great, thank you. Dr. Daniels, I want to switch to you, and before, I guess in kind of setting up this question, a couple things. There was a quote I saw from, I probably won't say the name right, Akeem Man. He's the Senior Director of Quality and Patient Safety Policy for the American Hospital Association. And I saw him quoted recently saying this: if you talk with just about any hospital leader across the country, they would put workforce as their top 1, 2, and 3 priorities. There's a recent Kaiser study that just came out, just saw this about 2 weeks ago, highlighted a number of hospitals they were focusing on in the Pacific Northwest, talking about how they were closing beds and eliminating services because they can't find and afford staff. Dr. Daniels, you oversee talent for WellStar, and so I'd like to ask you to talk about this from a provider perspective. What's going on? What do you see as the path forward?
Absolutely. Thanks so much, Shane. And good morning, everyone. As Shane mentioned, this is a huge challenge for us across healthcare, but specifically in the provider space. It has forced us to really completely reimagine the way that we look at talent. I think for so many years, healthcare was able to say, okay, we're short on staff, let's turn up the talent acquisition dial, maybe we need to raise pay and be a little bit more competitive. But we're operating in a completely new landscape, and that calls for really different thinking. And so first and foremost, I think, we as, a large healthcare system are thinking a lot about the mix between what I would call kind of your build versus your buy talent. So while talent acquisition, we can buy talent that's ready to go. Huge focus on strategic workforce development and a lot more of building talent. Specifically when we think about, career pathways, for example, for like our clinical support staff, that's been a huge focus for us at Wellstar. Whether that be our CMAs, our CNAs, for example, even to really working with high school students, doing nursing summer camps to get them interested in healthcare, see if they can start to enter the profession. And I think that's helped us in many ways, not just to be able to get the talent, but we're also seeing dramatically lower turnover with people that you invest in, and it makes sense. If you invest in somebody and help them, become a certified nursing assistant, that's paying off. We're seeing turnover of, people that are, coming through talent acquisition at maybe 58%, about 29% for those that are going through our CNA program. So some huge wins there. I think the third thing is really thinking about, our care models at the bedside, to many of your points. Thinking about how nurse extenders, care partners, how can they help more? And we know that's critical. And then I think the last piece that's really critical for us is really looking at that employee value proposition. And other industries, I think, that were more competitive, 10, 15 years ago for talent, they understood, this idea of employee experience and that it has to align to this consumer experience that you're creating. And I think healthcare has been we've been a little bit stuck in that, why wouldn't they want to come work for us? We're great organizations, we're mission driven. And there's a lot more pressure, I think, because of the burnout that Dr. Goldsmith talked about, to how you position your employee value proposition, your focus on wellness as an organization. How are you going to take care of folks? Are you really taking action around diversity, equity, inclusion, and belonging? And then, folks are seeing this huge swath of people that are working remotely, and clinicians are looking at that saying, what does that mean for me? I want flexibility too. And so we have to start to think about differences in flexibility for our clinicians, whether that be different schedules, more kind of flexible working arrangements. For example, we have almost like an internal agency because these nurses wanted to take contracts and have agents, 13-week agency contracts. And so we've now got that in-house where we can pay them the same amount of money. They sit on what we call our kind of shared services West team, and they're able to sign up for 13-week contracts, not work for a period of time, work part-time, work as a PRN, 0.2 FTE. So I think there's got to be a really kind of comprehensive and integrated strategy to approach this. It's not getting better, and we're in a lot of pain.
So, I switch to Dr. Swan. Dr. Daniels, just one of the points you made was about attracting people into the workforce in different ways and earlier and all that. And so, we've talked about there aren't clinicians, it's not getting better. We're all looking to you, Dr. Swan, to provide all these great trained clinicians that are going to be coming into the workforce. No pressure, but it's all on you. If you talking about the current challenge that we face and how you guys are thinking about training the next generation of clinicians.
Thank you so much. It's really a true honor and privilege to be here. And I think even though you presented some numbers that in context may seem really grim, I think the fact that this conference have more attendees than ever before, and I think that the field of health is generally, we tend to be very action-oriented. I think knowing what the numbers are and placing them in context really gives us an opportunity to rethink this. So, as Shane mentioned, I'm the Dean of the Wellstar College of Health and Human Services, and within that college, we have multiple academic units. Our Wellstar School of Nursing is one of them, but we have several other academic disciplines. And so when we think about creating the pipeline for not only the clinical workforce, we had to think, I think, about health in a much broader context. And before I give some specific ideas, I sort of also want to give a shout out to our partner here, Wellstar Health. So you heard me say Wellstar College and Wellstar School of Nursing. What does that mean? It means a tremendous investment from the Wellstar Health System, and again, supporting higher education for training. In particular, with our Wellstar School of Nursing, they have invested millions and millions of dollars so that we can double the undergraduate program and produce more nurses. I mean, it's a really amazing, transformative philanthropic support, and I know there's another panel, obviously you're not there, but they're talking about the importance of philanthropic support, and I think that is something we also need to be very mindful of. But sort of the broader rubric of how we can fill the pipeline. I talked to some of our students in the room. They were not nurses, they were public health, although we probably have some nursing students. And one of them stood up, and as I asked, what should I tell the audience here today? And she said, we're ready, we're ready. So I think it's very important for us as we train the next generation of clinicians and health providers or people working generally in health, we need to convey that optimism. There is a unique time in health. Again, presenting the context coming out of the COVID pandemic is very important to look at those numbers. But I think the other 2 points I really wanted to highlight, in addition to this Wellstar partnership, we all need to think about healthcare delivery, just much more cross-cutting. Some of you may be familiar with the term interprofessional education. Sort of it's a buzzword in higher education in terms of how we link health providers or people are trained in health more broadly so that they understand each other's disciplines and also work more collaboratively and obviously more effectively. The other part of collaboration, I think, is the technology and innovation. I was walking the booths earlier here at the conference this morning, and if we think about technology, we think about innovation and capacity, we think about shifting the workload, in particular of those at bedside. How can we free up some of their time? So we've had some really interesting conversations in terms of the degree programs that we have. How can we complement those training programs with certain certifications? How can we offload the nurses in particular, since that is the workforce need that is most dramatic? I think Shane might have mentioned it, but we're about 1 million short nurses across the US and growing. So that is a really key priority, offload the workload for those nurses and figure out what other job categories we can fuel. But I think from the higher education perspective, looking at the pipeline, there's a strong demand in our programs. We are, one of the colleges at KSU that is still growing, and I think just because this is the era of health, I think we all realize we need to come together and address this. And the last point I wanted to say about all this is that I think what the last couple years have really shown us is that prevention is key, right? I think that as we strengthen our infrastructure, and again, I'm a public health person, so health infrastructure is always one of my things, but we have a totally new way to look at prevention, whether it's chronic diseases, infectious diseases, or other health burdens. And so I think we also need to come together and look at that. But I think even though the numbers are grim, there's also an exciting time for us to really innovate and think differently about how we go about protecting and promoting health.
Dr. Goldsmith, I want to go back to you here. We heard from Dr. Daniels about some of the different things they're doing in terms of how they structure really their relationship with the people working at Wellstar. So right now, about a third, just over a third of U.S. workers do some kind of gig economy work. And the estimates are that in 5 years, that number is going to go up to 50%. So I'd like to just ask you to talk about how you practice as a locum tenens, and maybe for some people that haven't even heard that term, that don't know what that is, and how you see kind of the nature of work and the relationship moving forward, the locums.
So as a ER physician, looking at our specialty, pre-pandemic, emergency medicine was a pretty competitive specialty. Like, there were few spots left at the end of the match. I would say post-pandemic, I think emergency medicine had more open spots than we've had in previous years, and I think that's because physicians and medical students are looking at their lifestyle more closely than in previous years. And so for me, when people ask me, like, what do you do? How do you practice? You don't work at a particular hospital. And they're like, well, is that like travel nursing? But yes, like I'm a traveling doctor. And that doesn't have to be the only setup. I mean, you can work in one place and pretty much sleep in your bed every night. But I found that having more control of my career as a locum tenens physician, having the ability to determine how much or how less I want to work in a month has been able to help me in terms of having more control over my career and what I'm exposed to. And so, especially important in these, past years with the pandemic, as I mentioned, the hospital system is pretty strained. And that means that you may not have many physicians working at one particular place, which means that it's going to put a stress on the people who are there. So locums allows for that opportunity to pick and choose what type of conditions you want to work in. And I know Dr. Daniels mentioned a lot of nurses are looking for that flexibility. That's something that I have as a physician. And one of the things that I've noticed is that medical students, residents don't know much about this as an option. We're used to staying inside of the box and finishing residency, going to a fellowship, getting a job either in a major academic center or in a community, and that's the course that you're supposed to take. And so what I've been doing is pretty much educating residents and future doctors on this as an opportunity to be able to have more control of your career and to, balance your work life a little bit better than what historically medicine has been for physicians.
Yeah, so I want to just note a few things in there. First of all, I was in a discussion, this was probably over a year ago now, and I was in a room full of physicians that were talking about burnout, and one of the physicians spoke up and he said, well, I practice as a locums, and if you're a locums and you're burnt out, you're not doing it right.
Definitely.
And so, Dr. Goldsmith, some of the words you used were control, flexibility, freedom, right? And which are things that are not unique to physicians to want. It's something that all of us want in our life, which is why gig work is growing so much. And so, Dr. Daniels, I'd like to actually kick this back to you if I could, because I know you talked about some of the things, some of the programs you guys are putting in place, but if you could just maybe kind of explore that a little more around, what are you seeing in the workforce, and where do you think that, how is it going to look moving forward?
Yeah, thanks so much. And Dr. Goldsmith is so right about just the shift in expectations from people that want to work today. And I think, we're lucky, sitting here in Georgia. I worked for Kaiser Permanente in the past on the West Coast, and over there you already see a much, higher prevalence of apps like Heal, for example, where people want, their provider to come to their door as fast as their, Chinese delivery food. And so, I think, especially being here in Georgia, we really need to start thinking about, these flexibility pieces much broader than even the nursing areas where we have. I think, because this is such a shift, when we think about the gig economy, yes, we have, true gig economy, but I also think you just have a big shift in the desire for mobility for folks. And so I am one of those dreaded millennials who has these expectations to grow and develop quickly. And I think when you look at traditionally how health systems are structured and how talent acquisition systems are structured, a role is posted. Primarily people from the outside apply. They may get thousands of responses that aren't always categorized by, internal talent first. You may open a posting first so internal talent can see it. But there really needs to be, one, a total shift in how you're thinking about talent acquisition in terms of how you're recruiting internal talent. And I think companies that are really, winning, in this war for talent right now, you're seeing a significant percentage of their movement and hires are internal mobility. And so that piece is critical. And I think there's different things you can do. One of the big efforts at Wellstar we've undertaken, specifically with our nurses in partnership with our Chief Nurse Executive, Jill Caseworth, is really around talent planning for all of our our whole kind of nurse population, starting with that nurse leadership. So understanding, in the next 5 to 7 years, what are all the career aspirations of our nurse leaders in the organization, or those who may be interested in nurse leadership, so that we can really start to target, as we're, even in recruiting efforts, for example, targeting our internal talent so that they have that movement. Because we know, if you look at the data, it's very easy to see what are the points when people leave, right? And they tend to be after, certain milestone markers. And so I think we believe that if we're able to get a lot more of that internal mobility as an organization, really track that and drive that as a key success metric, it'll help us to retain some of these folks more long-term. I think the last piece I mentioned is really just the effort, especially when we talk about leadership on succession planning. We often don't talk about, healthcare leadership, and we'll get into it a little bit later, but there's also a huge need to strengthen these leader pipelines within healthcare. And so I think that's another area where we really have to focus on mobility, so that folks aren't sitting in roles for too long, not only so that they don't leave the organization, but in order to really shift mindsets to think more as enterprise leaders, especially as healthcare is transforming. Having someone sit in the same role for 10, 15 years, it's not good for your organization, because they don't have the same understanding as if they had sat in different parts of the organization. So lots of work underway, Shane.
Yeah, that's great. We actually didn't tell you this, but I want to put you on the spot, Dr. Shaw, because you mentioned something actually right before we came in here about hiring within the Gwinnett Clinic and some of the challenges with kind of different expectations. And so it's great to say, like, we have to give people, flexibility and mobility and all those sorts of things. But at a kind of practical level, that puts pressure on the organizations, right? And so how are you guys dealing with that?
I just can't shake the image of me walking into somebody's house with a doctor bag in one hand and Chinese food in the other. I'm sorry, I'm still recovering from that. It's hard that, we're a relatively small organization compared to other healthcare players in the Atlanta area, and certainly across the country. And about a third of our staff has been there for over 15 years, which we're really proud of. Then we've got, another third that's been there 3 to 10 years, and then the other third, similar to most of your institutions, is turning over. And when you bring in outside folks, some really special things happen. You learn new things. They lift up the culture. They sort of bring relief, probably like when Dr. Goldsmith shows up. People are excited to see her. She's a superhero. But then they also start to bring in the expectations that they've seen other places, which may not be realistic in your market. And if you don't have really strong communication with your permanent staff, and particularly your leadership, your local leadership, your on the ground, your unit leaders, your clinic leaders in our case, about what we're trying to achieve over the next 6, 12, 24 months, it can create some friction about expectations. And, why is the temp person getting paid more than me? Or whatever that may be. What we're trying to communicate to our care teams is medical care is at its core relationship-based. And how are we going to reconcile the modern workplace job expectations, which have a lot to do with mobility, flexibility, and advancement, with a traditional model of informal relationships between bosses, staff, everybody working together at the bedside? And it's different when you work with your boss all day versus you see your boss once a week. And that dynamic creates a lot of opportunities for discussing advancement and career change, but can also create some friction when there's somebody else in the room who's new and getting all these new fancy things that you, as somebody who's served the institution and been loyal for a long time, may not feel like you're benefiting from. But I agree with Dr. Swan. We see a lot of demand from young people to come work in the clinic. In the past 3 years, we've started a gap year program, which has, I think, given students a lot of insight into how compelling a career in healthcare can be. And we really try to give them an opportunity to see what a balanced career might look like in healthcare versus other industries. And also, we're developing informal partnerships ourselves. You know, a small group like ours, we're not gonna be able to endow a college of nursing somewhere. But we have a great relationship with the University of Georgia College of Public Health. Some of our former interns are in the room today. And I think those kind of micro relationships are gonna help move us forward, and at least get through this period of the cyclical issue of someone's retiring, my workload's increasing, I wanna leave too. Hopefully they can bridge the gap.
Great. Great setup for you, Dr. Swan. So we've got different expectations, different models. What do you hear from students? What's that conversation like? How are you training them for this new kind of workforce?
So I think the issues that you see in the workforce in general, we already see as we accept our students to join our various programs, the whole idea about flexibility and mobility and career paths. I think in many ways the students are more savvy nowadays than they might have been in terms of mapping out where they want to be. They may not know exactly where they want to be, but they are asking, I think, the right questions, and sometimes, of course, it's hard and challenging in this kind of environment to predict all these different pathways. But I think we're doing a much better job adapting to the new generation of students and, of course, you know, what the health workforce needs are by mapping out different career paths and communicating to them. I mean, some of the issues that we also see is sort of the behavioral health related. They are looking for different opportunities, again, looking out for themselves as they should. And, you know, this impacts our faculty and staff, of course, too, because, again, this is kind of a shift we're seeing at all levels, not just at sort of the bedside healthcare delivery, but we see it upstream as we're training the next generation of healthcare providers or other health professionals or even health researchers. And so I think in terms of how we're adapting is that we're mindful of this. We're looking at the curriculum. Of course, it's very different depending on which degree programs they're earning. But I think there's also an expectations for higher engagement with technology. Again, not talking social media here, but as we're thinking telemedicine and all these other strategies, I mean, if there's anything COVID has taught us is that there's a great opportunity to leverage technology in many different ways. And so we need to think about how we incorporate more of that in the classroom. And so these are ongoing conversations that we have. But we also need to hear from our partners, right? We need to hear, what do you see on the healthcare delivery side, and how do we work upstream to prepare, you know, for that? Because that's what we're here to do. Mm-hmm.
So I want to pause here for a moment and just kind of remind you, Russ said this earlier in his opening remarks, but this is one of 2 sessions today where you get to ask questions. Nobody else wants to hear from you, but we do. So if we're going to take questions in a few minutes, so if you want to kind of tune out for a minute and think of something that is like a really smart sounding question, so you can impress all the other people in the room, that's totally fair, but we'll do that in a few minutes. Okay, so I want to start this with Dr. Shaw, and then any of the panel who wants to weigh in on this. So I want to kind of go into some specific topics. But Dr. Shaw, I'm going to start with you on this one, and we want to talk about primary care. Now these are numbers that I didn't go into in my intro, certainly could have, but I think everyone in this room is well aware of the limitations on access to primary care. We have fewer physicians who are entering primary care as a specialty. Get your thoughts on that, and how do we solve the issue of access to primary care? It's an easy question for you.
Yeah, it's a problem. Yeah. So I'm a primary care physician, and I see patients full-time still. And the pandemic was the most compelling case for anybody in the world to realize I need a primary care doctor. So we've seen, I think, increased patient demand to start having those relationships and get somebody in your life that if you get sick, you can call upon. So that's maybe one of the upsides of the pandemic, of reminding people how important it is to have a doctor. The challenges we face in terms of what we do in primary care and the services we offer and how easily you can get them were also explored more through the pandemic with some of the virtual care, with app-based care, and also I would say building relationships between the patients and the other team members. And I think that's where a lot of our focus is right now, is what can be handled by a medical assistant versus a registered nurse versus a nurse practitioner or a physician assistant versus the doctor, him or herself. And we're figuring that out. across the country, people are trying to answer this question. We will get some progress by helping stratify and clarify who does what. But the real issue is we don't have the best and brightest medical students and residents wanting to enter the profession of primary care. And until that problem is solved, we're sort of chasing our tails. In the statistic that Shane mentioned earlier about, a fifth or a quarter of doctors are going to be retiring in the next 5 years, that's going to affect us more than other subspecialties in medicine. So what we are trying to do at a small organization like mine is talk to our doctors about how their job is a scaffold for their life. It's not your entire life, but it's a scaffold to achieve your personal and professional goals. And how can we be flexible without breaking the bank and giving you what you want? And we were joking, before the session, that the question is really, what do you want? Let me see if I can give it to you. But as we're having more of those conversations, I think we're starting to get a sense of what is the framework that works for the modern physician, and we're having to change our payment system and our compensation structure to accommodate that, provide job stability, provide the pay that is commensurate with the work they're delivering, and we need our insurance contracts to follow that. And that is, I think, one thing I'd hope everybody takes away from here is most of you work with insurance partners in some capacity, and I'm sure we have some insurers present today. But the compensation structure for primary care has to reflect all the work being delivered by everybody on the care team, not just the doctor, him or herself. Value-based care is a very overused buzzword. I mean, anybody who's survived in primary care and practice has to be high value. I mean, you just can't make the margin otherwise. So the question is, how are we going to translate that from the patient's premium dollars going to the insurer to providing them with that high access, high touch that everyone's expecting? Basically, everybody wants 24-hour follow-up nowadays. 2-3 days is just really not good enough for more patients, for most patients. And we're having to walk that line and not burn out the staff, but still meet patient expectations. So to answer your question, I don't know. But we're trying a whole bunch of stuff.
Yeah. Any other thoughts on this? Dr. Goldsmith, I'm putting you on the spot a little bit here, but emergency medicine is often a proxy for primary care. Any thoughts?
I do feel like a primary care physician at times when I'm seeing frequent flyers. I have regulars that come in, and so we are often a resource for people who can't get in with their doctors, and that's because my primary care colleagues are overworked. They just can't lay eyes on everybody. They just can't get everyone in for that 24-hour follow-up, and so oftentimes that fallback's on emergency medicine, which now, going back to our strain on resources, leads to longer wait times in the ER and trying to have to figure out ways to help some of the lower acuity things that come through the door. And of course, sometimes we're getting more high acuity things that are coming from primary care, but we have to figure out ways to utilize advanced practitioners and nursing to help offload some of that burden from the ER. So it's a vicious cycle where if they don't have the resources that they need, then it falls on us, and then that affects the care that we deliver to patients.
And I'll just make one other point about the market has spoken in the proliferation of retail clinics, urgent cares, telemedicine to fill this gap. But the super hyper fragmentation from that is the reason we're not seeing better outcomes. So we have to collaborate and figure out a way to make that story work for the patient.
That's a great point. All right, let's pick another topic. And I did mention some statistics on this. And again, invite the whole panel to chime in on this, but I want to start with Dr. Swan. And it's on the issue of behavioral health. This is a tremendous issue. Dr. Swan, I know this is kind of an area of passion and interest for you. So just love to hear your thoughts on it.
It's a huge topic, and I assume you only want me to speak for a few minutes. But behavioral health, I mean, even before the pandemic, we had, the opioid epidemic started, we had increasing suicide rates, and all of that has continued throughout the pandemic. And so think now we have all these streams, bringing together. We've talked about burnout in the health workforce, and I think we can see burnout pretty much in all areas. And so behavioral health, and you mentioned the shortages of trained behavioral health providers. At KSU and the Ball Star College, we actually have some really innovative programs trying to look at how to train paraprofessionals, right? Really trying to increase capacity for the workforce by providing some really innovative training just to meet that kind of workforce demands. And some of that specifically in rural areas just because of the sort of the healthcare deserts in some of those areas. But it is something that I think no matter which kind of organization we work with or for, I work in higher education, but we need to be mindful, all of us, right? The behavioral health, given where we are as a society, that we really need to be mindful how we treat people, how we engage, what the expectations are, and what the work culture, how we really set the work culture. I tell our faculty and staff all the time in our college that, we are the health college. We have to be good role models to our students, to other faculty, to our colleagues. And if we can't lead by good examples, then, what is the hope? But I think that maybe a take-home message is that we need to integrate behavioral health pretty much in everything that we do, that we have more of a holistic view of it. We can't just say behavioral health sits somewhere separately and we're not addressing it. So maybe that would be the take-home message for everybody. What can you do in your organization to uplift behavioral health and look out for your colleagues or those that you serve?
You have thoughts on this topic? Dr. Goldsmith, I'm going to pick on you again then. Because, so the ER is kind of the dumping ground for all of the problems in healthcare. Right? Everything else fails and all shows up in the ER. But I will tell you, across the country, this is an issue we hear is a huge issue, and especially with some of the requirements that came out a few years ago around psychiatric screening for patients that come through the ER, and it becomes a significant issue for length of stay in keeping patients in the hospital when we can't get that screening. So again, putting you on the spot. I mean, but what are you seeing as this issue, and how's it showing up in the hospital?
It's definitely an issue, and one of the things that I'm fortunate to experience is the way that different hospitals approach it. Because I work in a few different healthcare systems, everyone's approach is a little different, and it really depends on what resources are available. So you can tell when a system is strained for resources because that patient may sit in the ER for 2-3 days waiting for placement. One of the things that I have to be mindful of is the fact that sometimes the resources that we have to help triage these patients, making sure that we are doing the right thing and it's not a decision made because we don't have the resources. There's some systems where, we have dedicated staff to take care of those patients while they're waiting 2 or 3 days, but sometimes they get lost in the shuffle. And even more so now that we are strained for beds in the ER because we're holding to take care of, ICU critical care patients, we're just pretty much just trying to make a broken system work for behavioral health patients.
Yeah, it's such a multifaceted problem, and this is an area of interest for me as well, and something that we really deal with a lot. I saw, so I quoted the survey earlier about shortage of 500,000 behavioral health workers within the next 5 years. There was another thing they said in that survey, in that study, that they said in 5 years, half of U.S. states will be facing a shortage of behavioral health workers. When I read that, it almost made me not want to use any of the information from the study because it feels to me like a discrediting statement, because I don't know of any state today that isn't facing a shortage of behavioral health workers. And it manifests in so many ways. We see it with my hospitals, let's say particularly in the ER, but it shows up throughout the entire healthcare ecosystem. And in addition to not having enough workers, there's not enough downstream beds, as you said. And so there's just a lot of challenges there, and we won't have to continue to go into that. Okay, so one of the things I talked about as well in kind of the introduction was the challenge that all of this is putting on healthcare leadership. And I don't know who is in the room, but my guess is a lot of you would fall into this bucket. I can't tell you how many conversations I had during 2020, and especially really that winter of 2020 and 2021 with hospital CEOs, COOs, chief medical officers, chief financial officers, administrators saying, I feel like as someone who's a leader in healthcare, it's my moral obligation to see us through the pandemic, but then I'm done, because this is the most stressful thing that I've ever been through. The problem back then was that we all thought that, oh, well, now the vaccines are coming, and so we'll be done by like the summer of 2021, and it kept going on and on. But so Dr. Daniels, I want to kick this one back over to you, and again, welcome any of the panel to chime in, because it's not just an issue of a drain or turnover among healthcare leaders, but your view also is that it's really a different mindset among leadership. So I just want to open this topic up to you because I know it's an area of passion for you.
Yeah, thanks so much, Shane. I think to your point, there's not a single time that workforce comes up that you don't see neck and neck, lack of skills and capabilities to execute on that strategy with, the strength of that leader bench or the leader pipeline. And so I think, to many of your points, the skills that are required of healthcare leaders in the future are different than the skills that may have, been required today or 5 years ago. And so if you look at, reports from McKinsey or Gartner or any of the research around this, around what are those key skills that are needed, what are the shifts in mindset that are needed, you consistently see, and no surprise here on this workforce panel, that, the ability for leaders to manage talent right at the top, and I think you're going to continue to see that. Secondly, really having skills around technology, digital transformation, and then third, the ability to really lead innovation. And if those are the top 3 competencies that are sought after and really missing in our leader pipelines today, how do we really address that? And how do we ensure, not just that our, traditional kind of, integrated leader development programs are addressing it, but quite frankly, one of the biggest needs is to really get those experiences for leaders where they're actually having experience that's shifting their perspectives and their mindsets. And so obviously you're seeing a lot of health systems with, their innovation hubs, circling healthcare leaders throughout that to try to kind of pollinate, the overall system and upskill leaders in this area. I think to your point, one area that's also not talked about with healthcare leadership is that, we often talk about, burnout of our providers, burnout of nurses, but when you look at a lot of the wellness data that comes back, healthcare leadership sometimes is far above even clinicians. And so, I think to Shane's point, you are seeing folks, leave the industry or say, hey, I'm on the provider space, maybe I want to go into biotech or another area of healthcare where, maybe the stress isn't as high. And so I think we need to be really intentional about what's in these roles and these positions, and thoughtful about how we get experiences for emerging leaders as they're growing in the organization. One thing we've really been trying to do at Wellstar is really use, open interim roles as an example, as opportunities to get exposure or experiences. For example, someone who's may have only been a CFO in their career, when you have that vacancy with, a hospital president role, for example, can you give them a broader experience? So those are just some of the things that we're doing. I think you're going to continue to see a fairly dramatic shift in this. And as you see, you're also seeing non-healthcare folks really coming into leadership as well.
Last one is Dr. Shaw. I mean, you guys have 18 locations.
Yeah.
You just talk about how do you think about this from a leadership perspective?
We talk a lot about servant leadership in healthcare, which is a nice way of saying, a really, really hard job to be in charge. My phone is here because I'm looking at the time, and I glance, I have like 19 messages in the past 10 minutes, and I have an away message up too. And the challenge we have is, particularly from the pandemic, I think it's gotten out there that this is not the easiest or most fun job that you could have as a talented professional. So we've historically relied a lot on the mission, but the mission is really not at this point enough to attract people to come run our organizations and help bring us into the future. the mission is part of it, and you want everyone to be mission-oriented. So, Dr. Daniels made so many good points about the ways that we're exposing younger leaders, early career folks to opportunities and what those look like, but we have to put guardrails on them. And right now, we just don't have any guardrails on what are the parameters of being a physician leader or a nurse leader or another health professional leader. What does that look like for you to have a sustainable world and a sustainable life going forward? And we're trying to do that, but we need to develop a workforce that recognizes it's not going to look just like a big tech leadership role. It's inherently not, because this is a blue-collar job in some ways. You have to walk the halls of the hospital. You have to be in the clinic. So there's also an emotional tax that we talk about that you pay as a healthcare leader, and we see that more in psychiatry and other fields where the work that you're actually doing, the substance of the work, is draining. So how do we account for all these things in creating redundant leadership roles? And that is where we spend a lot of our energy. We want redundancy, and we want the ability for people to rotate if they're getting tired in a specific role. So what that requires is exposure to different clinics, different sites, different departments, and the leadership team has to view themselves as a team. I have a lot of young people come work for us and say, what's my title going to be? What's my name going to be on my resume? What do I write on my resume? And I can't answer that question for 1 to 2 years, because we are just part of the management and leadership team. That's it. And we'll figure out what works for you, but the attitude has to be, it's just as important for me to take care of my coworker as it is for me to take care of the patients, and also to serve the needs of the practice or the hospital that I may be working. And those are mind shifts that we really need our educators to help them understand when they're coming into the healthcare profession. This is not traditional leadership. And I think that's a movement from servant leadership towards more traditional modern leadership, but we're going to have to meet somewhere in the middle.
Any thoughts? So I'm going to bring up one more topic, and would love to hear really everyone on the panel chime in on this one, if you would. And then I will give you notice that after this topic, we're going to open up for questions. So be prepared for that. I want to talk about the topic of rural versus urban medicine. And again, everyone in this room understands the specific and unique challenges of both. But you know, since we're talking about workforce on this panel, we're talking about access. You know, specifically, really talking about some of the challenges in rural medicine in the state of Georgia. You know, as we all know, once you get outside of metro Atlanta, especially, and really, frankly, once you get into Central and South Georgia, access becomes a much different environment than it is here. So I'm not going to pick on anyone specifically. Whoever wants to start and time in, but let's just delve into this topic a little bit.
Yeah, I'll mention, you know, from a workforce development perspective, I think to some of Dr. Swan's comments earlier, you know, academic partnerships are critical for us as an organization. And for us, you know, when we think about, you know, a hospital out in West Georgia, for example, partnering with local institutions there, whether it be, you know, West Georgia Technical School, for example, is really critical for us to make sure that we have, you know, some sort of a pipeline. You know, I think when you talk about, you know, even our efforts, for example, with our, you know, agency nurses, it's much harder to get them down to areas that are more rural or more remote. And not only that, but I think we have a tremendous commitment to those communities that we serve as well. And so it's really important that we are investing in developing some of that talent. And so whether it's partnering with high schools to get them involved in, you know, our nursing programs and summer programs, really starting at a much earlier age to get folks starting to be interested in the healthcare field is critical. I think in our service areas, we've got about 1,500 students alone in high school that are exploring some sort of a healthcare early career pathway, which is just critical for us.
So I'll say as a traveling locums ER doctor, some of my first contracts I finished in 2016, so this is even before everything with the pandemic, a lot of my contracts were in rural areas. And that's because of the difficulties that you have in bringing in talent. And so coming from Chicago, which is where I trained, that was a completely different experience in practicing in rural Georgia. But that's one of the beauties of having the ability to use a locums physician or, tap on us as a resource, is because if you are short or your staff is feeling overworked because you don't have enough physicians or you don't have enough staff, that we can come in and help relieve some of the challenges that you have in maintaining a full staff. So.
Yeah.
We have 4 clinics in medically underserved areas. It's a federal designation, and I think this goes back to Dr. Daniel's point about buy it or build it. I mean, we just have not had success buying it because, generally speaking, the school system becomes a critical issue for anybody who's moving to those areas. And in the context of this room, if the school is not good where the clinic is located or the hospital is located, that creates a lot of pause for whoever you're trying to get to go work there, even if you're paying them, above market. So I think it's for us about trying to find people who are from those areas, providing them with local resources to get educated, and really want to be back in those environments. So we're struggling with those sites staffing more than anywhere else, and I think that's probably not a unique situation, but it's a tough nut to crack.
Well, and I don't know if I have really any good points to add, except that, the research shows obviously that there are tremendous disparities, and so the populations in those rural areas are not just only underserved, but have a lot of health concerns that really need to be addressed. And so the question is, how do we reach them?
Yeah, and to that point, I mean, one of the things we hear from doctors like Dr. Goldsmith when they go into rural areas is the patient complexity that can actually be quite high because of some of the social determinants and things we heard about earlier. So by the time they do show up, the acuity is much higher. I can tell you from our perspective, 10 years ago and past, the majority of our business where we were working with doctors like Dr. Goldsmith and others were going into rural areas. This is not a new problem, obviously. It's always been challenging, more challenging for rural areas to attract specifically medical talent, all clinical talent, than in metro areas. What's changed is that for us, that's no longer the case. Now metro areas make up the majority of our business, which the learning from that is that what it means is that even big metro, well-known healthcare systems, healthcare employers are having trouble attracting talent, which means that for rural providers, it's even worse. Because they're having to do all the things to compete that you've heard on this panel in order to attract and get talent, and rural facilities, frankly, just don't have some of those resources. And so, obviously, people like Dr. Goldsmith and others, this is just it's a huge challenge for our states, challenge for our countries, challenge for our industry of how we're providing appropriate levels of care. And I think we have to think about what that is in some of these areas a little bit differently than we have historically. Compared to when was it Harry Truman that came out with a law and said, funding that every county should have a hospital. The way we think about care in rural areas has to change, because I can just tell you from a workforce standpoint, we cannot keep up. When the metro areas are having to be the way they are, the rural areas cannot. All right, well, that's all I have. And so hopefully you all have lots of great questions. Otherwise, we're going to sit here in silence for the next 25 minutes. No, that's not true. But I do want to open it up. And is there a microphone that we have? Great, there's a microphone coming around. So would ask, maybe you kind of stand. I think we've got someone right here. And if you'll wait for the mic so everyone can hear you, that would be great. The gentleman is walking briskly to get to you.
I'm Florence LaCroix. I'm at the Andrew Young School of Policy Studies at Georgia State University. This question is for Dr. Daniels, with her being at Wellstar, and they're a very active member of Georgia Hospital Association. And then I want to ask Dr. Shaw's thoughts on it too, and anyone else. Georgia, the state of Georgia, has one of the most limited scope of practices of any state. We now have very, I saw that smile. We have very good studies in high impact factor medical journals showing those states, comparing those states with good scope of practice laws versus very limited, there's better health outcomes. So my question is, what is Georgia Hospital's opinion on this? Because if we do not inform our legislatures, they're just going to keep it limited, or any of the others of you. Thank you.
Well, thank you so much for the question. And you know, what I'd say is, one, I definitely understand, you know, where your question is coming from. I obviously came from Kaiser Permanente, based on the West Coast in Los Angeles, and so very aware of kind of the differences in scope. And I think, to your point, there's going to have to be some change within that. I can't give you kind of the official Wellstar statement, if you will, of exactly, you know, our opinion on it, but what I would say is that we do recognize that's an issue. You know, one of the conversations we were even having, you know, earlier was around advanced practitioners, and, you know, I think it's an issue across the board, you know, and I think as, you know, the healthcare crisis gets even worse from a workforce perspective, it's one that all of us are really going to be faced to answer, so couldn't agree more.
I'm sorry, I thought you said Dr. Swan. I can give you Deep Shaw's official statement because I don't work for Wellstar or anywhere else. We are, you know, there have been bills in the legislature for at least as long as I've been in practice in Georgia about broadening scope of practice. And I think from a physician perspective, not necessarily a clinic perspective, what you're looking for is, yes, you want a literature base to support it, but the data is all pretty new, 5-10 years old. But you're looking for a comprehensive care environment. And everything has to be balanced when we increase scope of practice for any group of people. And it's not just nurse practitioners and physician's assistants. We see this with CRNAs. What can medical assistants do? What can certified medical assistants do? What can an LPN do? So that whole issue has to be addressed for the problem to be solved. And concurrently, we have to have our malpractice rules and all those kind of licensure issues all sort of unified. And I think the next step is, and I'm going to put this with Dr. Swan, is really unification of what credentials mean. And that is something that we're all trying to figure out, is, you know, what kind of experience comes with XYZ credential and what is the scope of practice. And most medical professions try to self-regulate to avoid government regulation of what the profession can and can't do. And nursing has done that probably better than any of the other societies. So I think it's an internal issue that will make a lot of progress over the course of my career. But I think who does what and feels comfortable doing what they're doing is really important. I think Dr. Goldsmith and I can both attest, the last thing you want to be is a clinical provider doing something that you don't feel comfortable doing. So we don't want to put people in that situation.
I mean, I couldn't agree more. And so there's lots to work to do that, and I think the workforce shortages that we're currently facing really needs to accelerate these kind of conversations and to make progress, because obviously the needs are totally there.
Yeah, one of the fun things to do in a party is to get a doctor and nurse into a discussion about scope of practice. It's always entertaining. I will say, to your point, I think, I'm not exactly sure on this number, but I think it's now 23 states have for nurse practitioners where they can practice. Is it higher now? Okay, so, yeah. Oh, okay, last time I looked, it was under half, but yeah, where nurse practitioners can practice without supervision, and it really has started in the states that were less densely populated because of an access issue. So, great topic. Thank you. Next question here.
My name is Tariq Hussain, and I've come from technology background, so probably Dr. Monica can answer that question based on your experience in the space. Have you seen any initiative or focus around using robots to support the human element? Because it's I consider it a wrong perception, inhumane, view of robots taking over jobs. So are you seeing any usage of robots in the healthcare space, either within states or outside?
So interesting. So the use of robots, for those of you who may not have heard, I can't really speak to robots. I mean, again, it's a really broad topic. And I think the perspective you were coming from, robots replacing workers, that's not sort of what we're doing in our end in terms of the training our clinicians. But I want to say that we obviously in our simulation labs, for example, we have very advanced robot sort of simulators, but that's for training practices, right? That's for our nursing students to learn how to treat different health conditions. So that's not about robots sort of replacing the healthcare workers. I don't know if there's somebody else maybe better to speak to the healthcare delivery. Obviously, technology is advancing and there's lots of opportunities, but that's really not my area of expertise.
Yeah, I won't talk to the care delivery side, but I'll build on your point, Dr. Swan, really just around the use of technology, even as we're thinking about training and developing our workforce. So to your point, the world of simulation has changed dramatically, and I think as we think about how we're going to train our workforce, we're piloting different, virtual reality learning technologies, for example, with different areas of our workforce. So whether it be, handling how to handle tough conversations around leading change through virtual reality, or we've even got a pilot going on with our EVS staff called MedVR, where they actually go through and are practicing wiping down and cleaning a room. It'll give you percentage of, competence, how clean was the room, where did they miss stuff. And so I think technology will continue to really infuse the way that we grow and develop our team members. And I think to Dr. Swan's point, as we're working with our academic partners and even going out to technical programs within high schools, they've now got state-of-the-art technology that they're using to help folks really get into healthcare.
To add to that, I won't say we're robots, but telemedicine is a way that we can replace a physical body being present on the spot and still being able to deliver care. One of the things, you mentioned gig work. One of the things that I also do is take call for nursing homes, and I do that via telemedicine. And one of the benefits to being able to do that is I'm able to go in the room with the patient and not physically be there. I'm able to have the nurse place a stethoscope on their chest, and I'm able to listen. And I'm able to, with the nurse or LPN, I'm able to do a physical exam and determine what that patient needs. So I wouldn't say we're like a full, it's like a hybrid model where you roll the computer into the room and the camera, and I can actually still deliver care to patients.
Hello. Hi, I'm Tracy Rug, Dr. Tracy Rug. I'm going to counterpoint and add to my colleague. I've been a practicing nurse practitioner for 27 years. I'm PhD educated. I have worked in primary care, worked in critical care, and I've worked in oncology for the last 27 years. I still am a practicing nurse practitioner. I have practiced in 3 states. I practiced in the state of Ohio for 20 years. Practiced in the state of Florida for 6. I'm new to Georgia. I've gone back in time. This is the worst state for a nurse practitioner to practice in. We have 57 years of data since I've been alive, 1965, when the first pediatric nurse practitioner program was introduced in the state of Colorado. To, by the way, meet a shortage of physicians, pediatricians, okay? So it's all cyclical. There is no shortage of advanced practice professionals, which is the APRN and the physician assistant bundle, okay? Now, we need to turn our sick care system into a healthcare system. I would think that everybody on the panel agrees to that. So we need to work collaboratively with our physician colleagues in developing models instead of being competitive, which I believe the state of Georgia is, because they have not come into this century. And listening to the IOM now, Academy of Medicine report, which is now 12 years old, into getting with our legislators and being politically active in taking care of the patients. This conference is all about how to increase the workforce, how to better take care of our patients, how to do preventative care. And it all boils down to healthcare policy and being and advocating for our fellow human being. And we really need to get off the competitiveness between physicians and nurses and really come together for what's going to benefit humanity in the state of Georgia. So I would behoove the panel to, and the leaders at this conference, to do that. Thank you.
So you see what I mean? Now it's a party. The second best one to that is to ask a older physician about younger physicians' willingness to take call. That's a fun one too. Yes, next.
Hi, I'm a KSU student with public health education. Right now we're taking courses about patient education and health coaching. In your opinion, how do you see patient education evolving and making sure that we're worrying more about primary care and making sure that the nurses aren't being overworked, getting that primary education and being able to make sure that the patients are absorbing and not just like overwhelmed at that point? Because a lot of times, I know from personal teachers telling me, if their kid just got diagnosed with severe asthma or whatnot, they're more worried about their kid. They're not necessarily absorbing all of that information that they're needing. So how do you think that we can go about bettering the patient education field?
I'll take a stab at this one. I'm really delighted to hear the emphasis on primary care, and it sounds like that's coming from every corner of the room. So at our practice, over 50% of our patients, our first language is not English. So we have a lot of opportunities to work with patients from across the world, but that creates some challenges in patient education, both in terms of a resource standpoint and also just not having materials really that are relevant and speak to them. And one of the other kind of layers of this is there's different education levels within those languages too. So health literacy is a term that we use to describe our ability to communicate health information to a patient and their ability to absorb it. But to your point about technology, one of the other questions, this is a space that I think actually really is ripe for innovation about communicating with patients. And I don't know if Dr. Goldsmith has worked with this at all, but there are quite a few now AI-enabled audio platforms that are available for physicians and other care providers to have in the room when they're talking to patients. And right now, those are often designed to decrease administrative and documentation burden for the physicians. But I think there's a real opportunity for those to also have a role in playing back to the patient what was just discussed with them. And I can tell you, we know when we leave the room that the patient didn't understand. And you feel horrible, and you want somebody to go back in and re-educate them. So I think there's a lot of interest on all sides in a very collaborative, I think, environment for that to be addressed.
Great. Hey, next, over here.
Hi, my name is Subbu Venkat. I'm a director of Lean at Wellstar. My question is on the lines of the scope of practice. So 15 years ago, I was at a conference in Orlando where Don Berwick was talking about same thing the lady mentioned, there should be less healthcare, not more healthcare. And we are $4 trillion down, and if you remember the opening statement from Robert, FDA Commissioner, China has got 5 more years of lifespan if you live in China today. So numbers are staggering, and all it happened was, it had the Zoom technology and telehealth was out there, but COVID had to come to even turn on that pipeline. So remember that. So if somebody's telling me that innovation is happening, I have to question that, right? Innovation is happening, okay, right? So there was a study out there 10 years ago from Harvard where a lady went to underserved communities in all over the country and looked at underserved population and was looking at people with diabetes, all the chronic conditions, and asking them why they didn't take the meds. Access was definitely number one. Number 2 was trust in the system. So this lady was sitting in McDonald's where all these gentlemen and ladies would frequent and made a connection with them, and she's a pharmacist, by the way. So she made the connection and started to give them the meds, and slowly but surely there was a measurement done which showed that there was progress in both diabetes and blood pressure. The point is, if we keep doing the same things and just saying that your census is going to be 1:6 today or 1:7, and think that it's going to change, it's not going to change. And today's graduates, they don't have the patience that we had 20, 30 years ago. They're not going to be loyal to the system. They're going to try it 2 years and say, I'm off, because they have Amazon clinics and Walmart clinics down the road. So the question I'm trying to ask is, I kept hearing the same things I heard 5 years ago, 10 years ago. I'm not hearing anything new in terms of workforce enhancement. That's my question. What is new happening? Thank you.
Well, I think Dr. Goldsmith's point is people are trying to create new roles that speak to the modern life and modern lifestyle, and we're still in the infancy in this in healthcare. And she's probably trailblazing more than most of us have as a care provider myself, and I think we're really following the lead to see what works and what makes people happy.
Definitely. One of the things that I'm fortunate to be able to do is talk with medical students and residents. I love mentorship, and a lot of times they're wondering, how did I create this career that I wanted? Something that I didn't feel comfortable with was just being thrown into the traditional box. And I think that's something that we have to expose. Number one, expose our training professionals on looking outside of the box and not feeling like they have to follow this traditional path, because we have the ability to create the career that we want. And I know a lot of older physicians are trained to get a job, stay loyal to this particular organization. And I think we learned that over the course of the pandemic that doesn't always work. A lot of people were unhappy in their jobs. And so I think having the ability to create the career that you want, that is something that a lot of times residents and medical students don't feel they are empowered to be able to do that. And so educating them on what their options are, and that they do have the option to not just work in this particular career, work here, but to also explore other opportunities like I have in telemedicine, like I have outside of the ER working in nursing homes. And so I think that's one of the important things is teaching them that they have options and that you don't have to follow this career course that maybe worked for someone else, but actually creating something that brings you a sense of fulfillment.
So really appreciate the sentiment behind the question, and I'm going to talk about this just for a second, because I think this is a good way to kind of wrap, and I'm going to ask one last question to the panel, and I warned you about this one, so hopefully you thought of something good. But it really is the right question of, okay, we know we have a workforce challenge in the country moving forward, like in all industries, specifically around highly trained, highly educated, high-skill positions. In healthcare, all joking aside, it's particularly severe. There are only a limited number of potential solutions to that. And I would talk about 4, and we have heard about 3 of them on the panel. The first is, all joking aside, scope of practice is an issue. We have to have all of our clinicians practicing at the top of their license. We have to think about care teams and how they interact with patients, and particularly in our state, I think we really need to think about how that works. So the reality is that we cannot train enough physicians quickly enough. We simply don't have the throughput capability to train the physicians that we're going to need. Our advanced practitioners, we can train much more cheaply and much more quickly. And then you think about that all the way down through. So from a workforce standpoint, we have to think about that. The second is telemedicine. You've heard this kind of mentioned, Dr. Goldsmith talking about some of the things that she's done. there was a lot of hope over the last 2 years, and in 2020, when the reimbursement rates were changed for telemedicine because of COVID, there was a lot of hope that, okay, finally we're there. And we're not. And a lot of the things that were done very smartly during 2020 were not made permanent. And this continues to be a barrier to being able to provide telemedicine, which is clearly a way to increase the number of patients that can be seen by given providers, and especially from a geographical perspective. The third is from a technology perspective. One of the things we hear from our doctors all the time is that they spend way more time sitting in front of a computer dealing with an EMR than they do with patients. And that compared to when they first started practicing, they spend less time with patients and more time dealing with technology. We have got to be able to free our highly trained experts up to do more in patient care and less with administrivia. The fourth thing I would mention, we haven't talked about this, is immigration. Every labor challenge we've had in the history of our country, starting with the building of the Transcontinental Railroad, we have solved through immigration. One of the things that nobody realizes is that during COVID and during even the second half of the Trump administration, legal immigration was almost completely shut down. We bring in tens of thousands of nurses from other countries into our country every year. That didn't happen for almost 4 years. And it's a big problem. One of the things I think that is behind a lot of that is that, and this was said earlier as well, that as industry, we have to lead the way on this, but we do need the partnership of our policymakers on every one of those issues. All right, that's all I have to say about that. This is the lightning round. Last question. For each of you, you have to answer it. I want each of you to make a prediction and finish this sentence for me. In 10 years, you would be surprised to know that blank. Dr. Daniels, you go first and we'll come this way.
I appreciate that. So I do want to first just acknowledge the question that came in because I think it's an important one. And I think one of the things I just want to point out is that healthcare from a talent and workforce perspective has been 15 years behind for, right, 50 years. And so many of the things that we would like to do, I think we've got to get caught up in some of the basic foundations and building blocks and just understanding of the relationship between an employer and their employee base or their contingent workforce or the workforce overall. So I just want to acknowledge that. I think, many of the things of where in 10 years healthcare will be, other industries are already there. And so it's not as exciting. I think when you think about a fully enabled, AI-powered talent marketplace, I think other industries are already there that is able to connect people with the learning that they need, all the programs across, not just what they offer, but more importantly, all the programs nationwide that offer certification programs and, degrees, upskilling. And then connecting them to roles and movement throughout the organization. So I think that's one, and I think the other piece to really pay attention to is the actual structure of job roles in organizations. So in addition to the scope piece, I think, when you look at like the burnout that's happening right now, and you look at what's happening in areas that are ahead in talent thinking, like Singapore, Israel, for example, well-being being actually built into job roles, and then transitioning, especially in leadership roles, to much more kind of generic roles that Dr. Shaw talked about, in that if we need an agile workforce, having a job description, if you think about it, it's archaic. I don't know if you've ever gone and read your job description of what you were hired to do, but I guarantee you a lot of what you're doing in your role is not what you were hired to do. And so stepping back so that you're able to pivot resources to more align to the most urgent problems.
All right, each of you gets 30 seconds. We're almost out.
Okay.
Dr. Goldsmith.
Okay, so I think this ties in everything that we've talked about with, use of advanced practitioners, what we learned, what our weaknesses were during the pandemic in terms of who we're taking care of. I would be surprised to know that we have actually made progress in addressing taking care of underserved populations and those who are not getting the care that they need. I hope that we can say in 10 years that we've made some tremendous progress in actually learning from these lessons that, we took away from the pandemic and actually putting them into action and doing better for our patients.
You're here. Dr. Shaw?
In 10 years, I think you'll see patients have reclaimed their own health narratives, and they're proactively pushing for more health and preventative care and less sick care.
Dr. Swan?
Building on Dr. Goldsmith's point, there was so much I wanted to say, but I think building on addressing our health disparities, if in 10 years we realize prevention is really key to the demand for health care, and we're actively engaged on that, and thereby also reducing health disparities, we would all be a healthier nation.
Wonderful. Last reminder, remember to register for ACHE credit. Please join me in thanking our great panel. Appreciate your time.
All right, if I could get everybody's attention for just 1 second. We are about to perform what's known in this country as a miracle. We have 2 full rooms, and we have lunch behind you. And so if we can get everybody in, we have about a 15-minute period of time for everybody to grab a lunch and get back in here. We did box lunches this year. We know we had some feedback that everybody wanted an individually packed lunch, so that's what we did. Thank you to our wonderful panel. That was wonderful and incredibly insightful. But if you could please go ahead and get your lunch, come back in here, and then we'll have Dr. Ford give us our White House update, and looking forward to it. One other quick thing, and if everybody can hear me, I think I'm in all the other rooms as well. The other room beside us, we will not have enough seating in this room, so the other room beside us will have seating, and it will be simulcast in there, so you will not miss anything. So if you'd like to continue some conversations while you're in there, while you're listening, lunch is served both behind you, down at the expo table area, and let's watch a miracle in action. So thank you to everyone.